Hi, everyone, and welcome to the Perinatal Mental Health Conditions March webinar. We're so happy that you're here. Kaylee is having a fantastic time on her honeymoon right now, and she says hello from Lake Takapo in New Zealand. But it will be me presenting today for Kaylee. So as always, please type your name and institution into the chat. The optional share today is what's your favorite spring tradition? A few housekeeping reminders. Please mute yourselves when you're not speaking. Feel free to type your questions into the chat during the webinar. We'll look at them at the end. We will record the session and upload the recording and webinar slides to our website afterwards. We have a wonderful agenda for you today. I'm going to cover some announcements, then I'm going to hand it over to Dr. Tiffany Moore-Simas, who will share our perinatal mental health conditions bundle Pearl today on early postpartum screening for PMHCs. And then Dr. Nancy Byatt and Hannah will discuss treatment and follow-up of perinatal mental health conditions. With Hannah sharing about her lived experience with postpartum depression, anxiety, suicidal ideation, and the treatment she received for these conditions. Now, our general intro slides. Thank you to all of our participating hospitals. We couldn't improve perinatal mental health condition care without all of you. I just want to speak to this updated participation checklist slide. Given our bundle has been extended until February 2026, we have an updated participation checklist. Given the bundle will run for 18 months, monthly data submission has been changed to 6 to 9 months or more. Same with monthly webinar attendance. And our implementation feedback survey will be distributed again at 18 months. Otherwise, there hasn't been any changes. Thank you to our work group for their incredible work on this bundle. Again, we couldn't do it without you. Now I'll get into some Penguin, Massachusetts, and national announcements. I'm going to be sending the links that I usually do after Dr. Moore-Simas shares her Pearl, and they will also be distributed after the webinar with the recording and the slide deck. For Penguin announcements, as I just mentioned, our implementation has been extended through February of 2026. We hope that this is welcome news to our teams. Reach out to Kaylee or I with any questions. An exciting news, and hopefully many of you saw this in an email sent out yesterday. Our Penguin 2025 Spring Summit registration is now open. The summit will be on May 22nd, 2025, and will run from 8:30 to 4:30 p.m. It will be in person at the Four Points Sheridan in Norwood, Mass. The theme this year is Pathways to Hope and Healing, Advancing Perinatal and Neonatal Health. We're continuing with the same fee structure we introduced for the Fall 2024 Summit, $50 for physicians, $25 for all other care providers and professionals, and free registration is available for patients and families with lived experience and students and trainees. The registration page will also have our current agenda. Please scan the QR code on the screen or wait for the link in the chat to register. Given the presence of other events on the same day at the same location, our registration is capped at 300 attendees, so register as soon as you know you're available. Every spring summit, Penguin highlights the incredible work of our colleagues and collaborators, and this year is no different. We're still accepting nominations for our awards through this Friday, March 21st, to review guidelines for eligibility and criteria for each award category and to see our past award winners. We have opened a Penguin Summit awardees page. This link will be distributed today and after the webinar, and we will include the guidelines and criteria in our follow-up email as well. Now, we're happy to announce that our PMHC Bundle Toolkit has been published. You can find the toolkit, which has been designed to help support teams with implementation of this bundle at their institution, on our website. Again, one of the structure measures for this bundle, as many of you know, is the design of a resource page and resource mapping. To help with the completion of this, we've started our own Penguin PMHC resource page. This page helps to alleviate or elevate local and national resources and will be updated periodically to ensure that links and organizations are still functioning. On this web page, you will be able to see the last date that these organizations and links have been checked. Hopefully this is helpful. Now at the state level, we are continuing to announce Mass's DPH guidance on syphilis testing. Preliminary 2024 data indicated 18 congenital syphilis cases, which was an increase of 29% compared to 2023. We have shared the full guidance on our website, and we'll link to the Massachusetts announcement as well. We are also so excited to announce that as of the end of January, Mass Health has issued a standing order for prenatal vitamins and over-the-counter hormonal birth control. Mass Health members and health safety net patients are able to get these medications free of charge without a prescription from their prescriber. These standing orders are also shared on the mass.gov website, and the link will be shared soon. Penguin has shared CDC resources on contraception and STI testing, giving recent updates to the Centers for Disease Control and Prevention website. We will share the link to these resources in the chat soon and in all of our follow-up emails as well. The Massachusetts Mind the Gap Coalition is working hard to improve perinatal mood and anxiety disorders, and you can help. In the link I will send in the chat shortly, be able to tell your state representative and state senator to support the Moms Matter Act. You can read more at the link that I will send. The Massachusetts Perinatal Team is a consortium of Massachusetts perinatal nursing leaders, consisting of managers and educators. If you're interested in joining or have any questions, please email massperinatalteam@gmail.com. MCPAP for Moms, our state perinatal psychiatry access program, is offering trainings where they will come to your institution for grand rounds or trainings with affiliated obstetric practices. Please email Beth for more news, more information, or to schedule a time. Now, nationally, very briefly, the Institute for Perinatal Quality is offering 3 live virtual courses, the National QI Essentials course, the National Speak Up Champions course, and a simulation-based course for clinicians covering IA hydrotherapy and freedom of movement for laboring patients. Please refer to the links in the chat that I will send to read more and register. The March of Dimes is offering a free course on the use of low-dose aspirin. You will get 1 hour of CME, CPE, or CNE upon completion of the module. Please refer to the link to enroll or learn more. And the March of Dimes is offering the March of Change on April 16th, where attendees will receive information on priorities and meet with your state lawmakers and share meeting feedback with the March of Dimes staff. To learn more, register at the link sent in the chat. And now I'm going to turn it over to Dr. Tiffany Moore-Simus, who will share more about early postpartum screening for perinatal mental health conditions.
Hi, good afternoon, everybody. Thank you, Brooke. This is just a quick sort of shout out for screening and potential early postpartum screening. So just as a reminder, both the ACOG recommendation and the recommendation in the perinatal mental health conditions patient safety bundle is we screen at that first initial OB visit. We screen later in pregnancy, which is often many people are associating with the gestational diabetes screen. And then at that first sort of official postpartum visit, which can be anywhere kind of 6 to 12 weeks postpartum. In the ACOG's optimizing postpartum care, there is a recommendation at around 2 weeks to at least have a touch base around mental health and other issues. And so there's not a formal recommendation for screening at the time of delivery hospitalization. However, wanted to point out that a significant number of birthing people do not actually attend that traditional postpartum visit. It's approximately 40%, and there are some pretty significant, disparities in those numbers depending on race, ethnicity, and payer status. There was a recent article in MGH Center for Women's Mental Health that spoke to the literature around early screening and or screening at the postpartum visit. And so we thought as part of this Pearl, we would point that out. Just as a reminder to really meet the definition, the DSM definition of postpartum depression or depression in general, it's 2 weeks of symptoms. So if you are in fact screening at the delivery hospitalization and somebody screens positive, you may in fact be picking up symptomatology or a depressive disorder that has predated the delivery, or you may potentially be picking up kind of baby blues. But if those quote unquote baby blues extend out beyond 2 weeks, then you probably are, you need to do further assessment. You may be picking up postpartum depression. there is evidence around early screening and its association with depression later on in pregnancy. So, for example, one of the is highlighted. Pairing individuals or postpartum individuals were screened at 1 week postpartum. And then mothers with a 1 week EPDS score that was 10 or higher are 30 times more likely at 4 weeks and almost 20 times more likely at 8 weeks to exhibit postpartum depression symptoms. So if you are screening at the delivery, inpatient hospital stay or prior to discharge, and you have an elevated score, like any other time you have an elevated score, it merits assessment and close follow-up if treatment isn't initiated in that exact moment. And, another publication that was highlighted was individuals who were screened at 2-3 days postpartum. They used a cutoff score of 10 to 11 using the EPDS. And they concluded that it had good specificity, sensitivity, and positive predictive value for identifying, they use the term mothers with postpartum depressive symptoms between 4 and 6 weeks postpartum. So I think many teams are thinking about initiating screening at that delivery hospitalization. And so again, thinking about not enough to screen, thinking about what it means as it relates to next steps. And even if treatment isn't initiated in the moment, recognize significantly high risk for having a continuation of depressive symptoms and merits close monitoring. So that's our pearl.
Thank you so much, Tiffany, for sharing about this important topic. As I promised, I'm sending the links in the chat very soon. Now I'm going to transition into a discussion on treatment and follow-up of perinatal mental health conditions. As I mentioned at the outset of this webinar, Dr. Nancy Byatt and Hannah will discuss treatment and follow-up of PMHCs, with Hannah sharing about her lived experience. Before we get started, I want to highlight that given the content of this presentation, we encourage you to take care of yourself, however you see fit. Should this topic become too much for you, we encourage you to feel free to leave the webinar and return at 12:50 for the Q&A session if you're interested. I've listed some ideas for self-care during this webinar, but now I'm going to pass it over to Dr. Byatt and Hannah.
Okay, thank you. So it's a pleasure to be here. I recognize a lot of names in the boxes, so it's nice to see everyone, and especially many who I've known for a long time. So what we're going to talk about is Hannah and I are going to kind of talk through her experiences and kind of really talk through how I think Hannah, I'm going to ask you more about this in a minute, but you had an experience in which a lot of things that we know can really help with mental health. You had that experience with sort of identification, and we're going to kind of, through your lived experience, Hannah, we're going to walk through the sort of mental health care pathway. So from like detection, assessment, initiating treatment, following up on treatment, and then, till getting better, right? So that's what we're going to focus on. And to introduce myself, I'm Nancy Byatt. I'm a psychiatrist. Many of you may know me from the role when I was the original medical director of MCPAP for Moms. My role within that is now the director of research and evaluation. Aruj Haider is our current medical director. And what brought me to this work is a long time of having, working as a psychiatrist, being sort of frustrated when I was working with pregnant and postpartum individuals with how long it took them to get to see me, and how the perinatal care professionals I was working with kind of wanted to help but didn't necessarily have the training to do so. And that's what kind of led us to develop MCPAP for Moms and lots of other interventions related to it. And my passion for this work is also rooted in my own lived experience as well. So Hannah, I'll hand it over to you. And I do a lot of research in building capacity of OB settings to address this. Hannah, I'll hand it over to you to introduce yourself, and then we'll kind of talk through things.
All right. Well, so my name's Hannah. I am a registered nurse. I've been a nurse for about 10 years now, with most of my experience being in maternal health, labor and delivery, and patient care, as well as a little bit of outpatient OBGYN experience as well. I'm currently working the bedside on LDRP at Sturdy, and I also run a peer support group through Sturdy to provide support for perinatal patients in the area after my own lived experience coming across the need for additional resources. I'm the mom of 2 girls, currently in school to get my master's in nursing and public health. And as you've gathered through my lived experience, this really lit a fire of passion that I didn't know I had originally, that I am very vocal with my story and my experiences to help educate families and mothers, providers, anyone that will listen, so that there can be better outcomes.
Great. Thank you, Hannah. That is also my fire and lived experience, and it's so powerful. So thank you for being here and for sharing that. So as we know, and as sort of Tiffany was just alluding to, and we know, right, that the bundle really recommends screening consistently, twice in pregnancy, once postpartum, for both mood and anxiety disorders, right? And it also recommends really that we detect, right? It's screening, and that screening is followed up by an assessment. And then that assessment's followed up by actually offering treatment or referring to treatment. And then even after that happens, that it's followed up. And sort of how we think about high blood pressure in OB settings, right? That if we screen someone and they have high blood pressure, it's followed up and it's managed until the blood pressure's, at the range that would be the goal range. And so the goal is sort of doing the same thing for mental health in obstetric settings. So Hannah, I'm really curious to hear about your, starting with sort of like, your mental health challenges. And I'd like to focus the beginning on sort of how were they initially detected? Was that, if you could talk through that, that would be great.
Yeah. So when I had postpartum depression after both of my children. With my older daughter, it wasn't detected until, I believe it was after my postpartum visit, and it was my husband and family kind of saying, Hannah, something's not right. Leading to me reaching out, making that connection for my care team to, start taking those steps, which did end up, starting me on medication. And that seemed to be what worked. And that was the path. So in planning, knowing that we wanted to have another child after that, and after my experience with postpartum depression that time, I got really interested already being in maternal health, but with social media, how with certain interests and things, it can kind of start triggering like certain algorithms. And I got it brought a lot of different information, good information for resources and just education about postpartum depression, such as like, okay, if you have it once, you're more likely to have it again. So in knowing that, my husband and we talked about it with my OB through the pregnancy, that, even if I'm doing well at the time of delivery, mentally, I want to start on medication because I don't want to go to that point. I don't want to get there again. And that, that is the plan that followed. The big monkey wrench that kind of got thrown in there was a global pandemic that decided to present itself. So that was certainly an unexpected part of the situation, but that didn't change the fact that, like, we know this happened before, still going to plan to start on medication to hopefully, maybe not avoid, but at least soften anything from what I had the first time.
Unmute myself. A couple of things, Hannah, you pointed out, they're really important. Sounds like the first time it was really sort of your husband who noticed, right? And that's how kind of you got the help. And I think that points out sort of the importance of our natural supports. And then it sounds like when you had your second pregnancy, you had educated, speaks to the importance of education. You do that yourself. I know last time you and I spoke, we spoke about not everybody has the capacity to do that. So if we're working with, or the resources or what have you. So you did that for yourself, but you're also talking about how important that is. And it's great you were able to do that. And I think for all of us who are maybe seeing pregnant and postpartum individuals, educating people, letting them know if you had it once, that is the biggest risk factor for having it again, right? You pointed out that risk factor and you advocated for yourself. It sounds like, I don't want this to happen again. So important for us to think about that, because obviously we can't assume that everyone would do what you do or you did. And a couple other things I want to amplify about what you said. The other thing you talked about was prevention. I didn't actually mention prevention when I talked about the care pathway. I started with detection. Really, we should be starting with prevention. And it's something I think in healthcare overall that we have a lot of gaps with implementation, I think, in healthcare. We tend to be kind of reactive, right? But I think you're talking about, for you, it sounds like it felt really important for you to start on a medication And, you know, you use the word avoid, we could also use the word prevention, you know, so you wouldn't have that experience in the first, like the second time around, right? I think that's a really important piece. And even if it's not medication, that can be done through therapy. There's lots of ways. If we know someone has a history of depression, particularly postpartum depression, the biggest risk factor, we as clinicians and other care providers and I know care professionals can be thinking about what can we do to avoid it happening again, right? And to prevent that. Sometimes we can't, but at least we want to do the best thing that we can. And
Absolutely.
especially in the context of stressors, which for you was the pandemic. So yeah, and then tell me what happened about, so when you know, it sounds like you did start on that medication, right?
Yes. Yep.
And it sounds like then the pandemic hit. So what happened after that? Like how, you know, it's keep going with your story to the next sort of step. You talked about prevention and then, yeah.
Yeah. So by the time that when my daughter was born, it was June 2020. So we were still in the early stages, but in that summer lull where it was a little bit of some of that weight lifting off, able to socialize, but outside because the weather was nicer. The numbers were low. It felt a little bit easier than it was, you know, those first few months. I stayed on that daily medication. And I'll say that my care team, especially the nurse practitioner that helped to take care of me, knowing I had postpartum depression before, and knowing even I was vocal about some of my anxieties, even as a bedside nurse during a pandemic, being pregnant, was really good about just even checking in. I will say I wasn't, as a nurse, I don't always make the greatest patient. And it, again, was more my husband. It was, the summer was okay. It was once we got to the end of the summer, he started really noticing, you know, he's like, you're just not like, you're not yourself. You don't seem to like, just, you don't seem happy. I definitely was very quick to anger, like irrationally, in terms of like if the baby started crying, I would immediately just like in my mind go into this rage. Nothing that I would outwardly act on, but I could feel the tension, feel the anger. And I would explain to him, I'm like, I don't know, I don't feel happy, but I guess I don't feel sad. I don't know. I just felt numb and kind of robotic going through the motions. And he had to push for a little bit before I was the one to reach out, again, to say, you know, I think that this dose isn't working because I'm feeling worse than I was the last time on this medication. And that's when I reached out, called the OB office and talked with them about what I was experiencing, the symptoms I was exhibiting. And the decision was made, you know, why don't we try, you know, increasing the dose. And if my timeline's correct, I think this is around the time that I also started meeting, you know, they referred me to a social worker to start with, you know, counseling and therapy as well, in addition to it for that extra support.
Thank you. Yeah, so it sounds like your husband, it just sounds like your husband has really been a rock.
Like a boulder in my life.
Like a boulder, yeah,
yeah.
Right, yeah, exactly, better word, yeah. And so awesome for you. Also, what it kind of, when we think about things, not everyone, like I can't tell you how many people I've seen. I'm so many of us who want to ask who their biggest support. There sometimes isn't anybody, right? So sort of recognizing like that, you know, wonderful that you had that. And how do we think about when people don't have that, right? Not everybody has someone to you. How can we provide that kind of support? Because this is sort of getting to like, you were started on medication. It sounds like you were, for sort of prevention. And then it sounds like you were, you know, kind of, it sounds like we're relatively stable. And then it sounds like, you know, kind of started getting some symptoms and your husband was the one who detected that. Many of us work with people who may not, or they may not know, right? Like he sounds like he's very sort of aware and was able to really also kind of assertive with you and encouraging you, despite many of us are hesitant. Nobody wants to be like, oh, you know, it's very often hard for all of us, including myself, to acknowledge when we have anything that needs addressing from a health standpoint, including mental health. So kind of also thinking about like, how do we reach out to people when they don't have that too, right? Because that's really important for us to think about. And how do we let people know and kind of widen that circle of safety and trust, so that even that they would know to reach out to you, or just kind of having someone else in the circle so that if there's a concern and it's postpartum, they know to reach out. Who can they reach out to, and kind of thinking about that, particularly when we know there's a history. I think that's one of the really important things I'm thinking about, both for you and then also for people who may not have someone like you, which I think is not, I wish I could say it was common, but I don't think it is, you know?
No, you're not wrong. And that was especially after the fact.
Yeah.
There were a lot of things that I thought about in terms of like, well, what about, those women or those families that don't have that in certain instances. So definitely a lot of many pieces of my story. I consider myself incredibly lucky.
Yeah. And it's still hard. So it's sort of this continuum, right? Like it can still be really hard. So it sounds like, you started feeling like, you just used the word numb, you use the word, robotic. And then it sounds like, he encouraged you to call your OB, and then they did exactly what they should have, right? Like that makes sense to me. Just as a psychiatrist, like they increased your dose, and then they referred you for therapy. So they were sort of, we know that the combination of both is what works best, right, for depression and also for anxiety symptoms. So that's great. And unfortunately, you were able to do that. And that's often what we like, that's kind of the both assessment and monitoring. You called, they thought, okay, they did that sort of assessment, like, yep, it seems like the dose needs to be increased. We also need to add therapy on. It was sort of a combination of monitoring, because you were already on an antidepressant. It sounds like some sort of medication, and then likely an antidepressant, I assume. And then they sort of upped it, which is kind of a combination here of like, they're ongoing assessing you, and they're also monitoring and responding to that. What happened after that? And referring for therapy, which is often what needs to be done.
Yeah. So after that, because that was probably, around August or September that happened. And then, the fall rolls around, I returned to work. But also it was more quarantines, more isolation. It's like the world shut back down again. And I've always felt that that was one of the biggest contributors to that really escalated and really just made my symptoms and made this experience of postpartum so much worse than my first. It was around that time. I really just started feeling, it was like October, November when it really, really peaked. And I would say that's when I just I felt like I had no purpose anymore. When my daughter would cry, it wouldn't be this like instinct to want to go like nurture her and care for her. It was like it would then make me cry. And instead of me thinking, oh, I just had like she's trying to communicate with me, my mind was saying, she hates you. You're an inadequate mother. You're not, it's like that little devil on my shoulder feeding me these thoughts. And I started, even though we were already in COVID isolation, like I started really isolating myself more. Not really communicate. I'm big in communicating with friends and family. Started not to be doing that as much. And eventually it was to the point where it was initially like passive thoughts that, oh, it'd be kind of nice if I wouldn't wake up tomorrow. That actually feels kind of peaceful. Until it eventually reached the point where I was like, no, I don't want to do this anymore. Living this way feels more, painful than dying. And so I started like, I didn't, do any Google searches or anything, but in my head thought about the different ways. Well, I could, try this way, or I could, if I wanted to, maybe try it that way. But I never outwardly talked about it with anybody, especially not even my husband. Even at, at work, a lot of people, they weren't fully aware of how bad of a place I was in, because I was really good at masking it in front of others. And not, trying to put on, like if you see that antidepressant commercial where they just have that smiley face on a stick in front of them, that was me, just trying really hard to hide it, but on the inside in like utter turmoil.
Thank you for sharing that. A few things you said that I think are so important is you talked about sort of feeling really isolated, and you talked about sort of how it really impacted your relationship with the baby. And that's often how sort of it can manifest in the postpartum period, where people can perceive their baby's view of them in a way that they might not otherwise. And they probably wouldn't otherwise, actually. And the other thing that I think is really important when we think about sort of assessment and risk of suicide, right, and safety concerns, is you talked about death feeling like reassuring to you. It was comforting. And that's when it's like, that's scary, right? Because it's like, if it's not scaring somebody, if it's sort of like reassuring, then and I think often, you know, and it sounds like you said it felt hard to live that way. And I often, with what we see with suicide, is I believe that thankfully you're here, and like, you know, what's interesting, I want to point out, is like, even with your husband, like, you didn't even want to tell your husband, right? So that speaks to how like we can really mask these things. I think that's the other really important thing about what you're saying, is that you were, despite really being, it sounds like, very depressed and very kind of thinking about suicide, it sounds like you somehow were able to go to work to mask it. And it doesn't sound like people knew, and it doesn't sound like your husband even knew. So, and I think that's such an important point, because I think sometimes we have an image of like depression in a certain way, and depression could look like anything, like it could present like anything. And, you know, and one thing that struck me was, you said it felt reassuring. You felt like this was more painful dying. My view of when if someone does die by suicide is like, I don't actually think it is a choice. I think that people do it when that happens, it's because there isn't a choice. If they felt like they had a choice, it wouldn't have happened, right? It's like, someone doesn't have a choice to die by a heart attack. They also don't really, it just manifests differently, right? Because it's like, my experience, they're in that because there is no choice, you know? And so sort of, does that resonate with you, Hannah? What are your thoughts about that?
Yeah. It was so much where I felt trapped. I was very afraid. Part of the reason that I really didn't, you know, I kept so much of these thoughts to myself, because I was also afraid of really vocalizing how depressed I really was, and how, you know, how I was suicidal, because I was afraid too, of, you know, what are they going to do if I tell my doctor, if I tell my care team that I'm feeling reassured by the thought of dying, like, are they going to like admit me to a mental institution? Are they going to call DCF on me? And I had, you know, I would say there were times it wasn't as active, but I had passive suicidal thoughts in my first experience with postpartum depression that I didn't relay to anybody, and I kept those inside. And in doing the education and things in my healing journey between pregnancies, I tried to make a promise to myself that it's only going to help me by being honest with where I'm at and what I'm really thinking. They're not going to, you know, immediately call DCF and have you locked up and do these things. It's only going to help you to get the treatment that you need, even if it is more intense than what you had anticipated. So it was a hard acknowledgement. Especially I didn't admit that to my husband until I think it was a night in November of that year, when I finally, you know, broke down. I had hit my lowest low. He had taken our older daughter. It was a warm November night, and he had taken our older daughter outside to push her on the swings, and I was inside with our baby, just folding some laundry. And it was that she started crying, and I had just finally hit that point of like, I'm useless. Why am I here? Like the thoughts had never been as loud as they were until that night. And when he came in, he found, you know, he saw me sobbing. I was just a wreck. So he, you know, I was safe enough to at least be just in a room down the hall to kind of gather myself from sobbing. But he checked in after, and we had agreed, it was simple, like to not have to worry about dinner. We decided, we'll order pizza. And usually he's always the kind like, I don't want to pay a delivery fee, so I'll go pick it up. So when he offered that night, I had to beg him not to go, because I didn't feel safe, and I didn't trust myself not to do something to hurt myself if he left me alone. And that's when he finally knew really how much I was struggling. And that's when I also called my mom and talked to her to let her know really just how bad of a place I was in and how much it was consuming me. It did feel like a weight, kind of like letting that out, letting others in to know
Mhm.
how deep and dark my mind was. And to kind of let others in on that was I think the first step. It's like I hit that rock bottom, and that was the first step. And that's what I'll tell any moms, is that admitting you need help, acknowledging that is okay. And that's the strongest thing you can do.
Mhm. Mhm. Thank you for sharing all of that, Hannah. And the word when you just said it's the strongest thing you do, when you were talking about, yeah, I know, like I see the heart so big, like when you described your experience, the thought that was like the bubble thought in my head was brave. Like, because you're right. I mean, I like what you described for you to, share that. I mean, it takes so much courage and to be so brave to share those things. And I'm so glad that you did. And that and the other thing I think that's really important about what you said is that how that I want to kind of amplify is one, absolutely strength, courage, being brave. And then how actually once you moved through that, so hard to do it, right? Like I've had this experience myself too. You spend your whole life sort of like trying to avoid that any vulnerability, right? I mean, for me, I'll speak for myself, but like, and it's like when you actually acknowledge it and can move through it. And in your case, it was, really very much so, because you felt like your life, it sounds like what I'm hearing, but please add if I'm not getting this right, but your life was at risk and you were really like, it sounded like it was really, very acute. And once you acknowledged it and moved through it, like you said, it was like a weight lifted off. And then you were able to sort of like, it goes back to that like circle of trust again, right? And having that safety, like it wasn't just you alone in it, because then you can begin to sort of, because I think like when we feel depressed or anxious or whatever, like, or have thoughts of suicide, like it can take over in a way that it feels like that's everything. And when we share it, it's like, oh, then it's sort of like kind of allow us to we use the term psychiatry reality test and kind of know that this is not actually the whole world and there's other things. Does that resonate with you, Hannah? What I'm saying makes that, yeah.
Oh, 100%. Yeah. And something too, and even listening to like your thoughts on this, and I think what also helped in finally admitting that the true state of suicidality that I was in is, in the back of my mind, again, that little devil on my shoulder was saying, you're just a burden to your family. Like you're doing nothing but bringing them down because you're so depressed and miserable to be around. Like your kids are young enough, they're not even going to know the difference growing up without a mom. And same thing, like why would my husband want such a miserable woman to be his wife? Like he'll probably be able to move on and find someone so much better. And by admitting, like, again, putting that out there about what this internal voice and dialogue was saying, I was able to get the reassurance from my husband, from my family, to counteract that little devil on my shoulder saying that I'm a burden, for them to say like, you are not, and we need you.
That's very powerful. It's a very powerful description and experience. And I think you're exactly right that it becomes like it takes over, and it's like that's why it doesn't feel like a choice, right? It takes over, and then but if you share that, then other people are like, no, that's not like it can become really all consuming, right? Yeah. And then so when that happened, so your husband, you told your husband, you talked about it, you did that very brave thing to talk about it, the weight kind of started to lift. What happened after that?
So once I got that off, I felt I could like we felt safe enough to know, like, as long as I have him to kind of help be that support, like I'm okay, like we don't have to go rushing to the ER. We kind of made that decision. I was in sound enough mind to, kind of talk about it and say, all right, I think I had an appointment like the next day or within a couple of days with the social worker. And then we agreed that first thing in the morning, I would call the OB office and report like, okay, this isn't working, and explain what happened. So when I did, I called the very next morning and talked to my nurse practitioner, and she, first, listened, really good active listening, assessed for safety, made sure that there was a safety plan in place. And then her next step, and she told me, was about MCPAP for moms, and she reached out to MCPAP, knowing that, okay, the medication I had been on that worked in the past is not working anymore. And she wanted to be really certain that whatever change was made would help get me out of this space that I'm in. And yes, she was able to get in touch with MCPAP, someone at MCPAP, I believe, the same day, because I remember I talked to her in the morning and I had received a call back from her in the afternoon with the recommended medication and dose for that. And then in following up with my social worker, I had told her, those same those internal dialogue thoughts that I had said to you guys. And she said, I think you need more than what I can offer you, higher level of care. So she had suggested looking for, like partial hospitalization programs. She had said she was thought about like either Butler in Rhode Island or Arbor Fuller. And one of the points one of the just really standout things that made me realize like, oh my gosh, there needs to be more education is I, as the patient, had to be the one, and I consider myself so lucky to have known of this. I had to be the one to say, well, what about women and infants? Because they have a program specifically for pregnant and postpartum women. So I always think about like, what if I didn't work in the maternal health field, and didn't know to advocate for that? Would my outcome have ended up different?
Yeah, thank you for sharing that part. And it sounds like a couple things, like she listened. I heard you say that very strongly. Like that was really critical that you called. And how many months postpartum were you at this point?
Oh, let's see. If she was born in June, so probably like 5 or 6 months postpartum.
Okay. So it also speaks to the importance of going beyond like the 6 weeks postpartum, but how the OB setting could be. It's so like all this stuff happened. And I think this is not uncommon. So that's why I asked. Like I think we like to, we all know OB care is I think there's work being done to address this, right?
Yeah.
But it's like a lot of this happened after OB care is currently sort of structured to end. And so that's like just pointing that part out. Your NP, it sounds like the nurse practitioner you're working with was available and she listened. Like so important that we listen. Because how might it have been different if she hadn't listened, right? Like really, really important. And then it also sounds like great to know. She called MCPAP for moms, and then we're available for consultation, as I think, hopefully everybody knows. And then it sounds like the partial was really critical. And I think, and just so if people know, like if someone was ill and if this happened, the situation, any of our psychiatrists, it sounds like, I don't know that she called again when she knew that you were, when you were like, this isn't enough changing the medicine. We're always happy to talk and about what are the options for partial, differentiating what's the best level of care. We're always happy to answer questions about that at MCPAP for moms in situations like this. This is a lot of what we do. And we can even, to help differentiate that, we can see people with a medication question. So kind of just to, and we can usually get people within a couple of weeks. So just to add that for other situations, I should say. And then, but you knew, and I wouldn't have necessarily expected her to know, you got to women and infants. And what happened after you got to women and infants?
So I got to women and infants, and mind you, this is prime COVID time. So now we're talking like December 2020, January 2021. I was a patient in their partial hospitalization program. So I was, it was via Zoom, but it was still really, really helpful. just to be in a setting, I didn't really know what to expect. It's one of those, thinking like, oh my gosh, is this going to be like One Flew Out of the Cuckoo's Nest, where I'm in, with a bunch of people that I just can't relate to, that are so much sicker than I am. But no, it was it could be your neighbor. And it's like, oh, it was just moms or someone pregnant that needed the support and who was struggling. And I found it was just so helpful because it gave me the tools and the coping strategies to be able to manage and help kind of take control back from my emotions. It was complicated by the fact of also dealing with a very public loss of a family member who was actively dying from COVID at that time. So this whole experience was also complicated by grief and loss. And that was a struggle in itself, trying to, how do I prioritize taking care of me to, make sure I get back to the mind where, yes, I'm Hannah, I'm that Hannah that wants to live, versus, the family member trying to support her sister whose husband is dying. That was complicated, but having that support, even the staff there was helping with the grief as well, even though that's kind of outside of the realm of postpartum depression. Once all that kind of came to an end, because I believe the typical run for someone in the program is about 10 to 14 days, if not a little longer if they need it. The psychiatrist that took care of me felt I was a good fit for the IV brexanolone infusion, since that was still in the market at the time. And I was admitted probably a week after I finished the program, or a few days after I finished the program. That way I could attend all the services. I was admitted to the hospital to receive the infusion, and that's really when I feel like there was that turning point. Whenever I describe it to anybody, because a lot of people are like, well, what's it like? It's still just a lot of questions, even now, I think, with the oral medication. And when I describe that feeling to people, I say that infusion, like if you think of a dead car battery, when you jump that car battery, it's not like the permanent fix. It's that jump start to get the car moving again, to get it to the mechanic's office, to change the battery and perform whatever maintenance is needed. And that's how I reference that infusion. Is it gave me that jump start where I finally felt like I didn't have, like I had been walking around with a noose on my neck for 5 or 6 months, and at any moment I was going to step off that cliff. And it finally felt like that noose was loosened and off. And then I was able to function, be more myself, but also not have to wait that 4 to 6 weeks, which luckily by that point, I think we had found the medication and the dose that was working. But that way, especially for if there's a woman that hasn't found that yet, you don't have to wait that 4 to 6 weeks. So that definitely was a pivotal part in my journey, and what I think finally that was the like turbocharge to get me to my healing.
Well, thank you, Hannah. And it's a very good analogy about the battery start. I love that analogy about sort of like, it's like a jump start. And I think in general with medications, like they could be super helpful. They often need to be done with lots of other things, right? Like lots of things to maintain our mental health. And so, yeah, but that's a really good analogy. And I'm so glad that it sounds like the women and infants was helpful, the brexanolone was helpful. And I'm so glad that you had that experience in the end, that like you sort of ended that sentence with healing, and that's a wonderful place to be. Takes work,
Yes.
ongoing,
Yes,
at least to have that ongoing, but like, I think that's great because you were able to get that jump start. And so that I'm really glad to hear that. So curious to hear, Hannah, about sort of like, from your experience, what are sort of like take home points that many of us who are on this that might be, caring, most of us here are caring in some way or advocating for or working with pregnant and postpartum individuals. What are sort of like things that you think, I think people will probably already have a lot of take home points based on your really, really powerful story. What are sort of things when you think about it that you're like, these are really things that I really want care professionals in these settings to really be thinking about for to kind of care for people who are experiencing, mental health challenges?
I mean, one of the biggest things is to just take a second and slow down. By stopping and taking that time to listen to somebody, to hold their hand and take that little bit of extra time, it might set your day behind a little bit, but it can make a world of difference to that person that right in that moment is feeling like they don't matter. So to just, I know there's a lot of pressure and a lot of tasks on everyone's plate when it comes to, any patient-facing profession, but just to take the time. Even though it feels hard to find the time when it's someone that's struggling, it can really make the difference. I think also not only focusing on educating just the patient. If they're coming to their OB appointments with a support person, whether it's their husband or wife, whether it's a family member or friend, make sure that person is educated as well. Because as I made perfectly clear in my story, it was my husband that really played a big role in identifying a lot of things. So I think if they have a support system, have that support system educated. But also if you're all able to identify if they don't have a support system and if there's a way to address that too.
Yeah, those are really important points. So take a second and slow down, and recognizing also, you already pointed this out, that in healthcare, like I feel like the push is for us to rush more patients, less time, RVUs, like all this stuff. And it's like that, recognize that's challenging to do, however, so important. And people know, like, but the people we're serving know if we're like, they know. So it's kind of being able to sort of work against the pressures that we have to kind of be doing the opposite is really important. And I really appreciate your point about the family members. I would also, I would add to that also that you can even call them, like, even if they're not in the visit, right? Like, I remember once I worked with somebody who I was very concerned about, and she was her main support person was her pastor. And so I was like, and there was some concerns about suicidal thoughts, and I didn't want it just to be her and I. So I called her pastor. I said, this is my number. Call me if you have concerns about her. I said, who, like, is there anyone that I could call? So it's not just you and I worrying about you, and caring about you in this situation. And I called her pastor with her in the room, and he had my number. And like, I've done that with people's other natural supports in people's lives. And I have absolutely found that I've had patients, natural supports, call me and tell me something, whether it's postpartum psychosis or suicide. And I shudder to think what might have happened if they hadn't called me and I hadn't made that connection. So I think that's a really important point. Even if they're not in the room, that call can be made. And I feel like when I think about the most scary situations I've had, I've been most worried about people. Like, I think that has made that's been my experience too as a clinician. So I think that's a really, really important point. Even if not in a room, you can make connection. And I think, and if they don't have a support system, like you said, is there someone can you create that? And the last thing I'll say about what you were talking about is, like, you talk about slowing down, taking the time. The interactions we're having with people are so, so important, right? Like, and that's kind of, when we think about trauma responsive care, kind of, it can also be done in just changing that from, instead of asking, like, someone's late for their appointment, why are you late? But, like, well, it must have been really hard to get here. Like, I see that you got here half hour, your appointment was at 10, it's 10:30. It must have been really hard to get here. How'd you manage to get here? Versus like, why are you late? Like, it doesn't take any more time. You're just asking the question, but you're asking it a different way. So I think there's opportunities there too, and just sort of like assuming, that sort of shift from what's wrong with you, which I learned in medicine, growing up professionally in the house of medicine, to like, what has happened to you, and assuming everyone is truly trying their best. Sometimes people may feel like they have no choice in some of the things that are happening because of things that are happening from a mental health standpoint or physical standpoint or what have you. But I do believe that people really are always doing their best and kind of kind of changing the frame of when we talk to people, which is not certainly what I learned in the house of medicine where I grew up professionally and kind of rethinking that, right? So I think those are kind of the things that are occurring to me as I hear your story. And I know we only have 2 minutes. So just to kind of summarize, like, Hannah, thank you so much for sharing your story. It's so powerful. It's so moving. I think it's very profound. And I think that you sort of shared this in a way that I think there's so many take home points for everybody about how we can interact with people. And I'm so glad that you're on the other kind of, you talked about healing and that's the end of it that you're on. And I think it's appreciate your contribution to, that this webinar today. And I don't think we have like 2 minutes left. So I don't know if we have any time for any questions or anything, but those are sort of like, I think we heard some wonderful. And Hannah, any closing thoughts for you? Actually, I'll let me ask you.
I just want to, say thank you to everybody for, listening today. And I hope that in one way or another that, it either reinforced what you're already doing or, maybe helped you learn something new or think about it in a different way and know that really, as stressful as it might be for you to slow down and think, oh no, I'm going to be running late. If you take that extra couple of minutes, as coming from somebody that was given that time during what was likely a very busy time on a very full plate, it could have been one of those life-saving measures for me. So never be afraid to take that extra time with someone that needs the extra support.
Yes, thank you, Hannah, and totally agree. And also, I know, thank you for putting the resources in the chat. They, sort of some resources that we have from AIM, McPat for Moms, other things around addressing perinatal mental health, much of what, Hannah amplified today. And also, we're currently, kind of the stuff that Hannah was talking about, screening, assessing the whole care pathway. We're currently doing a study funded by PCORI to help integrate that. I'm going to put my email in the chat. If anyone's interested in learning more about that, it essentially is bundle implementation. So if anyone's interested in learning, so we can sort of do a lot of things Hannah was talking about today, please contact me. We'd be happy to explore working with you. And thank you again, Hannah, for being here, for sharing your story. Very profound. We appreciate you.
Thank you.
And thank you both so much. I'm going to drop Kaylee's email in the chat. If you have any questions about this presentation or for either Dr. Byatt or Hannah, please send them to her and we'll consolidate them and share the responses to the people who are asking. So thank you both so much.
Thank you.
Thank you.